Okay. Let us see. Let us see. Let us see. Let us see. It is live. Okay, guys. So can you see the screen? Yes. Let us see. Okay. Okay, guys. So can you hear me? बच्चा लोग जल्दी से बताओ. Say hi if you can hear me. Yes. Perfect. Okay. So hi guys. So we left at a very crucial point yesterday, right? Because it was like 1:15 a.m. So I thought we should stop the session. So are you ready for the rapid fire session tonight? Okay. And the best thing and the best comment that I got today was that, ma'am, why do you take session at 11 o'clock only at night? Do you get special power at that time? Why 11 o'clock? So the reason for this is that 11 o'clock is one time when I was preparing. This was one time when I used to feel very sleepy. Okay, so I used to feel like very sleepy, and if I somehow was able to keep myself awake for even 15 minutes, then I was able to stretch my studies for 2 hours at least. So this time is very close to my heart. Not from now, from the time like I have been preparing, because this is the time when I uh, get nap. Okay, and if I sleep at this time, I'm gone. And if I keep myself awake at this time, I am able to stretch myself for 2 hours, and that 2 hours are very, very precious to me, because I'm able to revise so many subjects, so many content at that time. And till now it's the same thing. If I'm able to stretch myself beyond this time, I'm awake, I can study, and I can read a lot of stuff. But if I sleep, I'm gone, I'm finished. Okay. Right, guys. So let's quickly go to the question without wasting your time. So here is the question on the screen. This is a 34-year-old male who presented with malabsorption, and on biopsy from the intestine, an ulcer was found. And in this ulcer, you are able to see these, what are you able to see? So you are able to see these structures here. Okay. Uh, what is the diagnosis? Okay, so let me tell me what's the diagnosis quickly. Okay, no, Farhana, it is not Giardia. Okay, so this is the one thing which students confuse. This is very, very important. Remember, this is a macrophage-like structure. And if you highlight, you can even see some RBCs inside this. This is what is called as erythrophagocytosis, which is a very typical feature of amoeba. Okay, so this is your amoebiasis. Okay, so this is a malabsorption, and this is caused by amoeba. Okay, so that's erythrophagocytosis, which you all have to remember. Now, once you're clear with this, remember, whenever we have an amoeba, it produces a special ulcer. This ulcer is flask-shaped ulcer. Okay, so this is a flask-shaped ulcer. Next question is, why is it a flask-shaped ulcer? Because muscularis does not allow amoeba to go further down, so this spreads horizontally, and that is why it becomes flask shaped. So flask shaped ulcers are very characteristic features of amebiasis, always remember. And the feature that you've seen here are these are the trophozoites of amoeba, and they usually show features of erythrophagocytosis. Okay, perfect everybody. Okay, now once you're clear with this, some of you answer that as Giardia. Guys, I've already told you, please go to the pap smear video and see that. I've already told you this. Okay, you have to differentiate trichomona from Giardia. So trichomona is trichomonas. Okay, so she has one undulating hair in one eye, whereas Giardia is a boy with the staring eyes. Okay, and a lot of mustaches here. Okay, so this is a Giardia. You know what is the characteristic feature of Giardia? That because this is a pear-shaped organism, okay, so this is a pear-shaped organism, it causes malabsorption, and you can see it in duodenum usually. And because it's pear-shaped, it usually folds on itself, and when it folds on itself, what do you see is it when it so this is a pear. When it folds on itself, sometimes it appears like sickle-shaped cells. So the best clue to identify Giardia on biopsy is that if you see sickle-shaped cells on the top of the villi, this is Giardia. So if you're lucky enough, it will show you his two eyes with the face, but majority of the times you're not lucky, and you will be seeing this sickle shaped cells because the pear folds on itself and they appear like this. So never confuse this. This is your Giardia, and you should remember this. It also causes malabsorption, so you should know. So these are the three important organisms that can be given to you in exam. These are the trophozoites, and if you are good enough, you can see these RBCs inside them. These are erythrophagocytosis of amoeba. And then the sickle shaped organism which you are seeing like this is nothing but a Giardia which has folded upon itself. And can you see these small spores on the top? Again, this is one of the very favorite organism which is asked. Okay, so this is Cryptosporidium. Okay, so if you look at this, if you look at the intestine, guys, and this is one question which is asked nearly always, you should remember we can have two sporidia. Sporidia means which is very small. Okay, so first we have microsporidia, which is micro means 1 to 2 micrometer in size. Okay, and that's microsporidia. It is very small. Okay, then we have crypto. So crypto starts with alphabet C, which is the third alphabet. So what comes after 3? 4. So the typical size of cryptosporidium, that is what is given in the question. It is 4 to 6 micrometer, and it is very typically given in exam. They can give you an HIV positive person presents with malabsorption, and the spores of 4 to 6 micrometer are found. This is very characteristic of Cryptosporidium that you have to remember. Okay, right. Now coming to the spora. Okay, so if I'm talking about sporas are big. Okay, sporas are big. We have two sporas, cyclospora and isospora. Okay, so coming to cycle is what usually you start driving when you are chota bacha, small kid, then you start driving. So this is cycle. So cycle is approximately what you start driving when you are 10 years of age. So 10 micrometer in size. Okay, but it's spore, that has to be more than 10. So if it is a sporidia, it is small, it is less than 10 micrometer. If it is a spora, big one, so it's more than 10 micrometer. So you start driving cycle at 10 years of age, so 10 micrometer size is for cyclospora. And then we have isospora. Isospora is when you say I love you, okay. So iso is a bigger organism, big one, so 30 micrometer in size. So isospora is I love you, so bigger one, 30 micrometer in size. Okay, remember, okay, the sizes, because the question is usually given on the sizes. And of course the another clue is Cryptosporidia is usually present on the surface, whereas isospora and cyclospora can be present inside the epithelium itself. Okay, but size is one which give the clue and is asked in the exam, so you should be very clear with it. Okay, right, so they are usually AFB positive organisms. Okay, so somebody, one of you asked, what is the Manoj Tyagi asked, how to differentiate trichomonas from Giardia. Remember, Giardia has two staring eyes, guys. So you can see two big eyes here. So that is Giardia. Whereas if you look at Trichomona, it usually has one eye and long undulating hair. And I've shown that image in the video of Pap smear, which was posted 2 to 3 days back. Just go to the revision videos. You'll be able to see Pap smear, which is an important tentative question to revise that, and you will be able to understand difference. Okay. Now, once you're clear with the organisms that can be asked, another important cause of malabsorption is this. Who is going to tell me the answer to this? So this is a normal person whom you can see the crypts and the villi. You can see the crypts and the villi. But look at this organism, if I'm this patient, if I'm saying, so what is happening to the patient? First thing that catches your eye is there is loss of villi. Okay. The second thing that catches, the crypts are getting elongated. Crypts are getting elongated. So what happens is, although there is loss of villi and crypts are elongated, the overall length of the epithelium remains normal. Okay, same. So initially it was on the top. That is, it was like a villi which is going on the top. Okay. But then the second time it becomes, crypts become elongated, so it goes deeper. So the overall thickness of the epithelium remains the same. Okay, so the epithelium doesn't changes. Number one, that you have to remember. And number 3 point that catches your eye is, can you see that there are so many blue color cells here? Okay, so these are lot of lymphocytes. So there is lymphocytic infiltration which you can see. So here you can see 3 points. There is loss of villi, there is elongated crypts, and lot of lymphocytic infiltration. Okay, especially with the classical history, okay, of gluten intolerance. This is the biopsy finding of celiac disease. This is the biopsy finding of celiac disease or celiac sprue. Remember, is this biopsy finding specific for celiac? No, it is not specific for celiac. So to diagnose it as celiac disease, you should not only have the histopathological findings, you should also have a positive serology, because it is due to antibody. So these can be anti-transglutaminase antibody. Okay, so you have to see the serology plus biopsy to make a diagnosis of celiac disease. And I told you yesterday we do Marsh classification for celiac disease. Apart from that, you have to remember what is gluten. Okay, what is gluten? Remember, robe. Okay, that is wheat, rye, oat, and barley are all gluten. So person is sensitive to all four of them. Okay, wheat, rye, oat, and barley. Apart from that, you have to remember, very important. Okay, so you have to remember, what is the important prognostic implication of this? Is this perineoplastic? Yes, because there is loss, there is damage to the epithelium. So yes, it can give rise to adenocarcinoma, number one. Okay, usually of the small intestine. Or second, because there is a lot of lymphocytic infiltration, and usually these are CD8 positive lymphocytes. This is a very important precursor for enteric T cell lymphomas. Okay, so it can cause enteric T cell lymphoma. So if somebody asks you which type of lymphoma occurs in celiac disease, it is usually T cell lymphomas, which you all have to remember. So remember, so diagnosis, you have to see anti-TTG and anti-endomysial antibodies plus histology. Is this perineoplastic? Yes, it can give rise to adenocarcinoma also, and it can give rise to lymphoma. So lymphomas are more common than adenocarcinomas. Okay, so it causes T cell lymphomas, right, guys? Yes. Okay, once we are clear with this, now we have to remember another important cause of malabsorption, which is again given to you in exam, and you should be able to identify this. This is Whipple's disease. So what happens in Whipple's disease? You see lot of dilated lymphatics here. Okay, so there are a lot of dilated lymphatics in the lamina propria, and it is stuffed with foamy macrophages. Okay, so this is an infective disease which usually occurs by the organism Trophirema whippleyi. That's the organism here. Okay, so it's Trophirema whippli, and in response to this organism, usually the macrophages come to eat up this organism, but they're not able to eat it properly. So undigested Trophirema whippli stays there. Okay, and what happens is all these macrophages become foamy, and they stuff the lamina propria. Okay, because they stuff, the lymphatics also becomes dilated. So you can see two findings: lot of foamy macrophages in the lamina propria, and there is dilated lymphatics. Now, because the lymphatics become dilated, these infected macrophages can even go to other tissues like bone, like joints and CNS. So this is a benign disease which can metastasize. So it can present with joint involvement and CNS involvement. If you have to confirm this, you have to put a stain, because this is an organism which is present inside the macrophages. So if you put a PAS stain, all these macrophages will be highlighted. All these organism containing macrophages will be highlighted, and they'll become PAS positive. So whole of the lamina propria will become PAS positive. And if you look at electron microscopy here, on electron microscopy, you can see the undigested bacteria. You can see the undigested bacteria which can be seen inside. So this electron microscopy shows you undigested bacteria. Please remember, the closest differential of Whipple's disease is Mycobacterium avium complex. So to identify that, you have to do a Zeal-Nielsen stain, because MAC is positive for Zn stain, whereas Whipple's disease is negative for Zn stain. Okay, so Zeal-Nielsen stain is very important to differentiate Whipple's from Mycobacterium avium complex. Okay, now, so that is why the diagnosis for, you have to identify, either you do PCR and identify that there's an infective organism there, or you see on electron microscopy, and that will confirm your diagnosis of Whipple's disease. So is everybody clear with this? Yes, is everybody clear with this? Now, another question I want to ask you this. So that is about your Whipple's disease, an important cause of malabsorption. Okay, and an infective disease with systemic manifestations is Whipple's disease. Remember that, okay? Now, coming to the next one, so that is about the malabsorption that you have to remember. The another important question that can come in exam is polyps, guys. Okay, and in polyps, the two favorite polyps which are asked in the exam are Hamartomatous polyp. So let us say a 2-year-old child with rectal polyp. Okay, so 2-year-old child with rectal polyp, and let us say 11-year-old female with intussusception. Okay, so the most common site for Whipple's is usually small intestine. Okay, now coming to this, remember, let's look at the two questions here. Okay, so let's say rectal polyp. If you are seeing here, so if you given a question, a 2-year-old child with rectal polyp, and you see dilated, cystically dilated glands. Okay, so big dilated glands, if they are seen in the polyp, this is your juvenile polyp. Okay, remember, that is very typical for juvenile polyp, and usually the mutation that is seen here is SMAD4. Okay, so what is a mutation? SMAD4. Okay, so remember, juvenile smashes everybody. Okay, so that is why SMAD4 is very common in juvenile polyps, and usually they have AV malformations. Okay, so what is the other manifestation of this? So usually they are associated with AV malformations. That is usually seen in this, and they can also have clubbing. They can also have digital clubbing. Okay, so because he smashes everybody, so he has clubbing in his hand, and he can have pulmonary AV malformations. Whereas when we talk about Peutz-Jeghers polyp, everybody should remember, this usually occurs in the jejunum. That's the commonest site for Peutz-Jeghers polyp. It occurs in the jejunum, whereas juvenile polyp is more common in the rectum. Okay, so Peutz-Jeghers polyp occurs in the jejunum, and usually the mutation that is associated is STK11, or this is LKB1. And remember, these are usually associated with mucocutaneous pigmentations. Okay, so they are usually associated with mucocutaneous pigmentation. So mucocutaneous spontaneous pigmentations are very, very classical for Peutz-Jeghers polyp. Always remember that, okay? And because it occurs in the jejunum, usually the patients will present to you with intussusceptions, okay? And what do you see here? Why is it a hamartoma? You will see arborizing muscle inside the polyp, okay? So muscle will go inside and start dividing. So if you look at the polyp where the muscle is dividing like a Christmas tree, think of a Peutz-Jeghers polyp, okay? So pigmentations are very common. So who's gonna tell me what are the other tumors which can occur with Peutz-Jeghers polyp? Always remember these two tumors, guys. So Peutz-Jeghers patients have a high risk of developing pancreatic cancer and sex cord tumors. Okay, so these are the very classical cancers which occurs in Peutz-Jeghers syndrome: pancreatic cancer and sex cord tumor. Okay, so this is sex cord tumor with annular tubules. So this can be asked to you as a question. Okay, so sex cord tumor with annular tubules, a characteristic feature of which polyp? Always remember it is Peutz-Jeghers polyp. Okay, right. Everybody clear with this? Yes, so remember that point always. Once you're clear with this is the chart from Robbins, which I always insist that you should revise before you go for exams. And of course, I'll be giving you PDF of it. But just to tell you the questions that come here. So the juvenile polyps usually occur in children less than 5 years of age. And mutation, you know, SMAD4. Okay. Apart from that, what is the associated malformation? They usually have AV malformations and digital clubbing. Now, the second question that they ask is Peutz-Jeghers syndrome usually occur in adolescents from 10 to 15 years of age. The mutation is STK11, and you always know that this is associated with pigmented macules of the mucosas. And I've told you they have a high risk of developing at least two tumors. You should remember: pancreas and sex cord tumors with annular tubules. Okay. Now, next polyps that they can ask you in exam is Cowden syndrome. I hope you remember the story which I've always told about Cowden. So Cowden, you know, what happens is the person becomes like a cow. Okay, so a very bad cow which I'm drawing. Okay, so whenever it is a cow, basically, so he usually has hyperkeratosis of hand and feet. And you see, whenever cow is there, there's a lot of, you know, something which grows out from the skin. So they have lot of skin appendageal tumors like tricholemomas. That is very, very common. And you say that, okay, so this is a cow. Okay, so I've seen it when I was 10 years of age. So P10 is the gene which is involved, P10. So that's the gene which is involved in the cow. And remember, when you see this, you say, I bet this is a cow. I bet this is a cow. So remember, breast, endometrium and thyroid cancers are very common in Cowden syndrome. So breast, endometrium and thyroid are very, very common in Cowden syndrome. And again, this syndrome is also called as P10 hamartoma syndrome. Okay, so this is also called as P10 hamartoma syndrome. Apart from that, you should remember Cronkite Canada syndrome. Again, I've always told you this is a syndrome. This polyps occur sporadically. So this is one polyp which is not inherited. So they are acquired polyps, and you know, it is like a person who wants to go to Canada and he's too old now. So like a doctor who wants to go to Canada, so by the time you are educated and you're ready to go to Canada, you're very old. So your age is more than 50 years of age. So obviously, you do why now you want to go to Canada, but you are very old now, okay, because you've studied so long. This is because you didn't had a lot of money, you didn't had any hereditary money with you. So it's a non-hereditary polyp. Remember that it's a non-hereditary polyp. And if you look at this person, see, because he's a doctor, he's working so much. So in Hindi we say nakhun kiss kiss ke padna. Okay, so he used to study so much, so he has nail atrophies. And बिकॉज वो इतना सारा धूप में काम करता था, तो he has hyperpigmented skins. And by the time the doctors, you know, if you see, they reach the postgraduate stage, they have already become bald. Okay, so they have loss of hair. So what are the three important features of Cronkite Canada syndrome? They have they have baldness, they have nail atrophy, and they have hyperpigmented skin. Okay, so these are the characteristic features of Cronkite Canada syndrome. So that's a very characteristic feature. It's a non-hereditary polyp, usually occurs in late age, 50 years of age. Okay, so that is your crocodile Canada syndrome, remember. Now apart from that, we have tuberous sclerosis, which all of you know occurs because of Hamartin, TSC1 and TSC2 gene, and TSC1 codes for Hamartin and TSC2 codes for tuberin. Okay, and there is an mTOR pathway defect, so it causes Hamartomatous polyp, and they can have a lot of angiofibromas. And I hope you remember which is the tumor in the heart which occurs in tuberous sclerosis patient. Rhabdomyoma. Which is the tumor in kidney which occurs in tuberous sclerosis patient? It is angiomyolipoma. It is angiomyolipoma. So these things you should always remember. Okay, so that's your tuberous sclerosis presenting with Hamartomatous polyp. Now let's come to adenomatous polyps, which is called as familial adenomatous polyps. And remember, at least 100 polyps, okay, are important. So remember, all the fab polyps, okay, are usually autosomal dominant, except Mutti associated polyps. Okay, so there is Mutti associated polyps. This is a DNA repair defect, and that is why this is autosomal recessive. This is autosomal recessive, and the number of polyps are also less in this. It needn't be 100 polyps. Okay, so remember, Mutti associated polyp is a unique polyp because it's because of DNA repair defect, and it is autosomal recessive. Okay, it's autosomal recessive, and apart from your intestinal polyp, they can also have gastric and duodenal polyps. So they can also have gastric and duodenal polyps. All the other, you should remember, FAP are associated with FAP syndromes, and there are two important FAP syndromes that you should always remember. These are Gardner syndrome and Turcot syndrome. So you remember the Gardner syndrome. What is the problem with Gardner? So he's a gardener, so he has nail. So what does he have? He has abnormal dentation. His teeth are abnormally dentated, and if you look at them, their abdominal muscles are very tight because they're working all the time. So what is happening to their abdominal muscles? They usually have desmoid tumors, and because they are gardeners, if you look at them, so usually if you're looking at the gardener, so he will have some tumor here. So it is an osteoma, and in the abdomen, it's a tight abdomen, so he has a desmoid tumor. Okay, desmoid tumor. And if you look at his teeth, he's having abnormal dentation. That's a very typical feature of Gardner syndrome. Okay, apart from that, this is Turcot syndrome. So Turcot comes from the word turban. Okay, so something in the brain he has medulloblastoma. So which tumor is seen in Turcot syndrome apart from adenomatous polyposis? This is called medulloblastoma. Please remember this point, guys. Turban tumor is not Turcot. Okay, so what is a turban tumor, by the way? This can be asked to you as a question. So which tumor is called as a turban tumor? Who's going to tell me? Will get a chocolate. Come on. So this tumor is called as cylindroma. It's a skin appendageal tumor. Cylindroma is called as turban tumor. Remember that point always. Okay, and this has zigzag puzzle pattern. Okay, so this can be asked as the question. Zigzag puzzle pattern is a characteristic feature of which tumor? It's a characteristic feature of turban tumor that you have to remember. Right, guys? Perfect. So Satvik gets a chocolate. Very good, Satvik. Now, another thing which we should know is a diseases of dysbiosis. Okay, so diseases of dysbiosis. So what is this dysbiosis, guys? Remember this point always. So whenever I'm talking about dysbiosis, you know, there are a lot of microbes which stay in our body, and these microbes form a flora inside us. Okay, so they are a very important part of the flora. So if you give antibiotics to your body, what is going to happen? Your good flora is going to die and your bad bacteria are going to grow. So very important disease of dysbiosis is called as pseudomembranous colitis. Okay, so pseudomembranous colitis is another question that can be asked to you in your exams. Okay, so this is a pseudomembranous colitis, which is a very important disease of, which is a disease of which is a dysbiosis. So when you give antibiotics, the bad bacteria grows, and this is typically caused by Clostridium difficile. Okay, Clostridium difficile. So whenever you give antibiotics, so Clostridium difficile overgrows, which produces lots of toxins, that is toxin A and toxin B, and this toxins basically cause damage. These toxins cause damage. Okay, and remember, so if you have to make a diagnosis of pseudomembranous colitis, you have to document toxin of the Clostridium difficile with characteristic histopathological finding. So if you look at the gross first, if you look at the gross, what will you see is that it's a pseudomembrane. That is, it's not a true membrane. So it will be like pus, okay, which will be covering the epithelium. So it will be like a pus covering the epithelium, which you can see. And on microscopy, that's a spot question that comes here. This is called as a volcano lesion. What is this called as? A volcano eruption. Very good, Avantika. You get a chocolate for that. So this is called as volcano eruption. If you look at this, this is how a lesion appears. So can you see here adherent fibrinous mucopurulent substance which is attaching to the crypts? That is a volcano eruption. It is something like lava is coming out from the volcano. So that is the typical histopathological finding. You see a lot of lava coming out from the crypts. So that is what is very typical of pseudomembranous colitis. Okay, right, perfect, guys. So that's pseudomembranous colitis, which you have to remember, which is a type of dysbiosis. Okay, now coming to the another question that comes in your intestine is, once you have characteristically studied it, so the identify the correct classical adenoma carcinoma sequence. That is the another question that they ask you. What is the correct sequence you have to identify? Right. So to understand this, remember, whenever I'm talking about carcinoma of colon, guys, you have to remember these two pathways very, very clearly. Okay, so that there's no doubt. So carcinoma colon can occur by two pathway. Either it is due to adenoma carcinoma sequence. Okay, adenoma carcinoma sequence, which is the classical pathway. So this pathway is called classical pathway, or the pathway, the second pathway, which is called here, is DNA repair defect pathway. Okay, so the pathway is DNA repair defect pathway. Okay, so in this, basically there is a defect in the DNA repair. So this basically leads to microsatellite instability. So this is the microsatellite instability pathway. So there are two pathways and both the genes are different, so you should know. So this pathway starts from loss of APC. So remember, APC is a tumor suppressor gene. So first one copy of tumor suppressor gene is lost, then the second copy of tumor suppressor gene is lost. And when both the copies are lost, there is activation of beta catenin. Okay, so this leads to activation of beta catenin. Okay, so if you're looking at the correct pathway here, so first one copy of the APC is lost at 5q, then the second copy of APC is lost, but the second copy, okay, wherever it's lost or it is methylated due to anything, beta catenin should get activated. That's the second step. So once the tumor suppressor genes are lost, now is the chance of proto-oncogene. So who is the proto-oncogene of the colon cancer? KRAS. So KRAS gets mutated and changes into oncogene now. So there is KRAS mutation. So who's going to tell me where all you see KRAS mutations, guys? Where do you see KRAS mutations? Always remember, colon cancer, pancreatic cancer, cholangiocarcinomas, and adenocarcinoma of lung. Okay, so that is one thing you always have to remember. And I hope everybody knows, never smokers never have KRAS mutation. Okay, so never smokers, people who have never smoked, will never have KRAS mutations. In adenocarcinoma, you know, adenocarcinoma of lung usually occurs in non-smokers. Okay, but people who have never smoked will get EGFR mutations usually. They will never get KRAS mutation. Remember that point always, always, always. Okay, so once KRAS mutation occurs as a third step, so first APC is lost, beta catenin gets activated, then KRAS gets mutated. After that comes your other mutations like P53 mutations, SMAD2, SMAD4, and the last is telomerase activation. Okay, then SMAD2, SMAD4 and P53, and the last is telomerase activation. So if you remember like this, you will always remember it. Okay, so the sequence of events is, first there is loss of APC. So once the APC is lost, what is the second step, guys? Second step is that you have to get beta catenin activation. So look at this pathway. So APC beta catenin, APC beta catenin, that means either A is correct or D is correct. Okay, the others are wrong. After this, what should happen? So after this, so this is, which of the following is the correct? After that, KRAS should get activated. So after that, KRAS should get activated. So that's correct. So KRAS gets activated. After KRAS, basically your P53 gets activated, and after P53, it's telomerase activation. Okay, P53 gets telomerase activation. So basically, both A and D appears correct. So there is some mismatch here. Okay, which should be there. Okay, right, so that is perfect, right? So the sequence should be known to you. That is the sequence. So yes, A can be the answer and D can be the answer, right? Okay, so the right, so once we are clear with this, next pathway that we have to remember is basically your DNA repair defect. So whenever I'm talking about DNA repair defect, okay, so whenever I'm talking about DNA repair defect, you have to remember, usually the DNA repair defect, whenever it occurs, okay, this causes microsatellite instability. This microsatellite instability basically is, this syndrome of microsatellite instability is seen in hereditary non-polyposis colon cancer. So name itself says it is non-polyposis. So there is no big polyps coming out. So it is something which is sessile. You cannot see coming out. So that is why it is usually associated with sessile adenomas. And these sessile adenomas are usually serrated. That is why these are called as sessile serrated adenomas. That is why they are called as sessile serrated adenomas. So why Ramya and Naveen are making faces like this? Angry faces. Why are you angry? Angry faces, or what is this cartoon character? I don't even know that. Okay. Okay, so this is sessile serrated adenoma, which you have to remember. So what do these faces mean, Ramya and Naveen? So this cartoon character, what does that mean? You should tell me that, okay? So these are usually associated with sessile serrated adenomas. And remember, another point that you have to remember here is whenever there is a, okay, so whenever we have DNA repair defect, I hope you can see this. Whenever we have DNA repair defect, okay, and this causes microsatellite instability, this usually causes activation of two molecules. One is BAX and other is TGF beta receptor 2. Okay, right, so TGF beta receptor 2, so it activates BAX and TGF beta receptor 2. Okay, so this is very, very characteristic. That feature you have to remember. So there was a question which was asked, what is the important genes which are altered in DNA repair defect pathway? This is BAX and TGF beta receptor 2, and usually it is associated with mucinous morphology. Okay, mucinous morphology. So why, Ramya, sad emoji? Why are you sad? Okay, you shouldn't be sad. Wrongly answered for previous question. Come on, for that you shouldn't be sad. This is not an exam, it's a learning exercise. So just remember, it's a good way to learn. Okay, so remember that. Okay, so BAX and TGF beta receptor 2 is involved. Now what happens is, sometimes what happens is, there is no DNA repair defect. Okay, there's no DNA repair defect, but microsatellite instability occurs. Okay, why does it occurs? Probably because, because of methylations, epigenetic changes. Whenever methyl group is attached to some molecule, it causes silencing, and that is why the DNA repair defect is not there, but silencing occurs in DNA repair enzymes, and that is what causes microsatellite instability. Okay, right. So in these cases, when there is no DNA repair defect but microsatellite instability is there, this is usually associated with BRAF mutations, usually associated with BRAF mutations. Okay, so BRAF mutations are also common in this pathway, but what is the difference? Difference is that they don't have DNA repair defects. It is due to methylation. Okay, now the third point that you have to remember now is, now there are no DNA repair defects, there is no microsatellite instability, but methylation has occurred. Methylation has occurred, that's all, but it hasn't caused instability. Okay, so in such cases we can have KRAS mutations. So in such cases we can have KRAS mutations. Okay, so this is methylation is there, but there is no microsatellite instability. So this is also called as CpG island methylation, which is also known as, let me see if you can understand this, CIMP. Okay, so that is CMG methylation mutator phenotype. Okay, so CMG, that is CG groups. Wherever CG groups are attached, there only methylation occurs, and this is a particular mutator group. Okay, so remember, whenever there is methylation and that causes microsatellite instability, this is associated with BRAF mutations. But if there is methylation but no microsatellite instability, then it is usually associated with KRAS mutation. Now, another question that can be asked you in exam is, which molecule is never affected in this pathway? Okay, that is DNA repair defect हो, microsatellite instability हो, methylation हो, कुछ ये pathway में कौन सी mutation, कौन सा molecule कभी affect नहीं होता? That is P53. So this pathway never have P53 mutations. Okay, so this pathway never has P53 mutation. So if they give you an MCQ and they ask you which molecule is never affected in this pathway, mark P53. Okay, mark P53. So what have you learned in GIST? If you have microsatellite instability plus DNA repair defect, think of two genes, BAX and TGF-beta receptor. If there is microsatellite instability without DNA repair defect, there's no DNA repair defect, but microsatellite instability has occurred, think of BRAF mutation. Now, if there is methylation, but microsatellite instability is not there, DNA repair defect is not there, think of KRAS mutation. Okay, so this pathway never has which mutation? P53 mutations. Okay, so that is the question that you should always remember. Okay, so that's the question on colon cancers which can be asked. Now I'm going to ask you a question. You're going to tell me the answer. Which polyp of the intestine is autosomal recessive? Remember, all the polyps of the intestine are autosomal dominant except muthi associated polyp. I hope you remember this, and we have talked about this already. So muthi associated polyp is due to DNA repair defect and it is autosomal recessive. Okay, that's what you have to remember. Okay, now let's go to the another question. Let's break from histo and go to hemat. Okay, which is my favorite. Okay, so giant platelets, thrombocytopenia, and cytoplasmic inclusion in the neutrophils. This is characteristic of which feature, which syndrome? Okay, so remember, this is very typical. Giant platelets, thrombocytopenia, and cytoplasmic inclusion. So whenever we have giant platelets, so blood cell counter usually counts the, remember this basis always, it counts the cells on the basis of the cell size. So it has made a cutoff. Okay, so that is why anything which is between 2 to 20 microliter is counted as platelet. More than 20 microliter to 200 microliter is counted as RBCs. Okay, so whenever the platelets become giant, that means they become equivalent to the size of RBC, the machine starts counting platelets as RBCs, and that is why the patient the on counter gets thrombocytopenia. But actually he doesn't have thrombocytopenia. It's counted as thrombocytopenia because of giant platelets. Okay, so giant platelets with cytoplasmic inclusion in the neutrophil is very characteristic of May-Hagelin anomaly. So May-Hagelin anomaly is basically due to MYH9 gene defect. So name itself says May-Hagelin anomaly, and this syndrome basically is associated with giant platelets and cytoplasmic inclusions. So, so this MYH9 gene abnormalities include many syndromes, okay, which will be just talk. But for now, just look at this. So these inclusions, this blue color inclusions in the periphery of the neutrophils, they are basically Dohle body-like inclusions. Now the next question is, what is Dohle body? Dohle body is nothing but dilated endoplasmic reticulum, which is usually seen whenever a person has infections, and then you can see Dohle bodies. Okay, so Dohle body like inclusions are usually seen here, along with such a big platelet which is equivalent to the size of RBC. This is called giant platelets. Apart from this, which is the other condition where do you see giant platelets? Remember Bernard-Sollier syndrome, but they will not have Dohle-like inclusions. So Dohle-like inclusions with giant platelets are typically seen in MYH9 gene disorders, especially May-Hagelin abnormality. So these disorders usually involve four syndromes. Okay, so one is May-Hagelin, which we just talked. Then we have Fechner syndrome, Sebastian syndrome, and Epstein syndromes. Okay, so we have four major syndromes which you should remember. And this gene, okay, MYH9 gene, basically codes for NNM and MMHC2A. Even if you don't remember, nobody's going to ask you this, so needn't remember this. But remember, there are four syndromes which you should remember: May-Hagelin, Fechner, Sebastian, and Epstein. So the difference here is Fechner wants to fetch everything in life, so he gets everything. He gets nephritis, he gets deafness, he gets cataracts. A person with macrothrombocytopenia, with Dohle body-like inclusion, with nephritis, deafness, and cataract is Fechner syndrome. Okay, whereas if you look at Epstein, okay, so Epstein says, I don't want my eyes to go, rest anything can go. So eyes are not involved, rest everything can be involved, and usually they don't have Dohle body-like inclusions. Usually they don't have Dohle body-like inclusions. Okay, apart from that, okay, the other May-Hagelin and Sebastian are very difficult to differentiate. You can't differentiate. Okay, right. Also, in the option, if you remember, we had a question, we had an option of Pelger-Hute anomaly, which we have already discussed in the rapid fire HEMAT discussion earlier. Pelger-Hute anomaly is your spectacle shaped neutrophils, bilobed neutrophils, and this is usually an inherited gene defect which occurs because of lamin beta receptor gene defect. It is because of lamin beta receptor gene defect. Always remember that. Okay, so where do you get a pseudo Pelget-Hute? Whenever the proliferation is rapidly increased and the neutrophils do not get time to divide, like CML is one condition where, or MDS, where you can get pseudo Pelger-Hute anomalies. Okay, apart from that, suppose they give you platelets like these, okay, which don't have color at all, like this, which do not have granules at all. These are called as gray platelet syndrome, and the gene defect here is NBL2, a very important tentative question that can come in exam. Please remember that and revise this. NBL2 gene defect is seen in gray platelet syndrome. A very, very important that can come in exam, guys. Okay, so I want you to remember this. NBL2 is seen in gray platelet syndrome. Okay, right, guys. Now, once we are clear with these inclusions in the neutrophils, we should also be knowing, where do you see small platelets? Small platelets are seen in Wiskott-Aldrich syndrome, which is the X-linked defect, and the gene is WASP gene. Remember that always. Okay. Perfect, guys. Now let's go to the next question, that is fixators, which is a very important question, guys. I'm not discussing stains here, which can be asked in the exam. Please stay tuned on my Telegram and Instagram, where I'll be posting tentative questions on stains also. Okay. So what is a fixator of pap smear? That everybody know. It's a googly question. It's 95% ethanol alcohol, ethanol. Remember, whenever we have a cytological smears or we have exfoliative cytology, it has to be fixed in alcohol. So alcohol is a very good cell fixative. Okay. Now, if somebody asks you what is the choice of fixative for this technique is karyotype. Okay, in karyotyping, the method of choice is Carnoy fixative. Okay, Carnoy fixative is the fixative of choice for karyotyping. So what is a Carnoy fixative? It contains three things. So because it's a karyotype, you have to have alcohol. Okay, so you have it 60% ethanol. Along with that, you add glacial acetic acid and you add chloroform. Okay, so it has chloroform, ethanol, and acetic acid. So remember the code CEA. So carnoy starts with C. So remember the three things which are present in this is CEA, that is chloroform, ethanol, and glacial acetic acid. Okay. Apart from that, we have Saccharomyces guys, which has 50% ethanol and 2% carbovax and 2% carbovax. And this is a fixative for sputum usually. Okay. So whenever there are fluids and you want to fix the fluids and transport them, especially sputum, you fix it in Saccharomyces. That's a 50% alcohol with 2% carbovax. Okay. Now, okay, so that is another fixative that you have to remember. In histopathology, when I'm saying, so heat is the simplest form of fixation, but we have chemical fixatives that they can ask you in exam. So we have coagulant fixatives, okay, like alcohol or acetone. Just now you've seen above, okay, all the exfoliative cytologies are usually fixed in coagulative fixatives, that is ethanols, okay. Then can you hear me, guys? Can you hear me, guys? Yeah, okay. Yeah, okay. Right. So that was your fixators that everybody has to remember. Alive again. Thank God I'm not dead. So let's come to the cartoon character once you're dead. Whose will answer this? Fixative defect. Okay. So fixative artifact. Thank you, Ramya. Thank you for making me alive again. So tell me, so which is this tumor which has a fixative defect? Come on, guys, tell me what is this? Orphan annii nucleus is a fixation artifact. I've told you earlier also. So therefore, papillary carcinoma of thyroid on FNAC does not show which feature. It does not show orphan annii nucleus. Remember that point always. And also, what is another fixation artifact, guys? Apart from orphan annii nucleus, who's gonna tell me? Lacunar cells of Hodgkin's. Okay, so lacunar cells of the Hodgkin's and papillary carcinoma of thyroid, orphan annii nucleus is a fixation artifact, and that is what is caused by formalin itself. Okay, remember that point always. And which is the most common mutation which is associated with this tumor? It's a BRAF mutation. So who's going to tell me which are the tumors with BRAF quickly? 100% of 100% of hairy cell leukemia. And if you write HCl in an opposite way, then it becomes Langerhans cell histiocytosis, that is LCH. Then two P's you have to remember: papillary carcinoma of thyroid and pilocytic astrocytoma. And pilocytic astrocytoma is the most common brain tumor of child. And apart from that, CM, that is colon cancer. Just now you've studied which colon cancer occurs due to BRAF mutation, DNA repair defect wala. So remember, it doesn't have DNA repair defect, but it has microsatellite instability. So CIMP, okay, mutator phenotype. That is it has CG island methylation, but and it causes microsatellite instability, but does not have DNA repair effect. Okay, and M say melanomas and N say melanomas. Perfect. So these are the 6 tumors which occurs with BRAF. Now all of these BRAFs are usually V600E. Exception to the rule is pilocytic astrocytoma, which is not due to V600E. It occurs due to separate pathway itself. Okay, so that's due to separate pathway itself. Okay, so rest all of them are due to V60E, right? So that's your papillary carcinoma. So once we are talking about thyroid, everybody should be able to identify this. I had posted this image on my Instagram also, guys. What is this? You see lymphoid follicles and cells with abundant eosinophilic cytoplasm in thyroid are called Hürthl cells. So these cells have excess mitochondria. So who will tell me what is the other name of these cells in other organs? These are called oncocytes. So oncocyte means any cell which has excessive mitochondria, okay, in other cells. In thyroid, the same cells are called Hürthle cells, okay. So you see Hürthle cells with lymphoid follicle, you know it is Hashimoto thyroiditis. Please remember, Hashimoto thyroiditis has high chances of developing two cancers. One is papillary carcinoma of thyroid, and second is it develops, marginal cell tumors or maltomas. Okay, so it can develop marginal cell lymphomas. Okay, marginal cell lymphomas or maltomas. So these are very, very common features of Hashimoto thyroiditis, which everybody has to remember. Very good, Satvik. Perfectly answered. So now next question, when you're seeing lymphoid follicles, so you should be able to answer something about lymph nodes and lymphoid follicles also. So what is this area which is shown in the image? Okay, so this is a lymphoid follicle and the central part of the lymphoid follicle is marked. Remember, the central part of the lymphoid follicle is always called germinal center. Okay, what is this zone called? This zone is called mantle zone. Okay, so this zone is called mantle zone. So remember, whenever we have germinal centers, so who's going to tell me which tumors arise from germinal centers? Either it can be a Hodgkin's lymphoma, and if I'm talking about non-Hodgkin lymphoma, remember Burkitt's, follicular lymphomas, and DLBCLs. Okay, DLBCLs can occur because of can arise from germinal centers. Of course, DLBCLs can arise from the post-germinal centers also, but these are the common tumors which arise from the germinal centers: Hodgkin's, follicular, Burkitt's, and DLBCLs. Okay, which tumor arise from mantle zone? Of course, you know mantle cell lymphoma. Okay, so this is your mantle cell lymphoma. And we have talked more about it in the rapid fire hematology quiz session, which was done 2 to 3 days back. So please go and see that. Okay, right. Okay, now just one question. What is the cell of origin of hairy cell leukemia? Memory B cell. Okay, so it's a post-germinal center tumor cell. Okay, so post-germinal center cell. Okay. So once you're clear with this, now let's look at the variation of this. Now what you are seeing is, you are seeing that the germinal center has become small and hyalinized, but mantle zone cells, lymphocytes, are concentrically wrapping around each other. Okay, so they are concentrically arranged like this. Like this. What is this called as? Concentrically arranged. This is what is typically called as uh, onion skinning. Okay, you can say it as an onion skinning, or you can say it as a lollipop appearance. Onion skinning or lollipop appearance, and this is very, very typical of Castleman's disease, guys. Okay, so Castleman disease, let's look at the question here. So this is a 50-year-old Lata who presents with sensorineural hearing loss and hepatosplenomegaly. She has a multiple lymphadenopathy, and if the biopsy of the lymph node was done, it showed this morphology. What is this disease the patient is having? So remember, hyalinization of the germinal center, onion skinning of the mantle zone lymphocytes is very characteristic of Castleman's disease. Castleman's disease is usually a viral lesion which is caused by HHV8. Okay, so human herpes virus 8, and it's usually a self-resolving condition. Okay, HHV8 conditions, right? Very good, Dipesh, Soni, and Ramya and Avantika. You get full points. Okay, now here's one more option which is coming here. Kikuchi. What is this? So what is this disease? Kikuchi. So let's go and see what is Kikuchi. To understand this, let's go to one question. Okay. So this is a 20-year-old female who again presents with lymphadenopathy, but this time when you did the biopsy, you found that necrosis was there, but there were no neutrophils. You know, necrosis is always associated with neutrophils, but here you're not seeing any neutrophils. You're seeing a lot of karyorectic debris, but there are no neutrophils. So what are these? So there are a lot of karyorectic debris, no neutrophils, and if you put IHC, you saw that they are all positive for CD68. So remember, CD68 is actually marker for histiocytes. That means their necrosis is there and there are a lot of histiocytes there. Okay, so whenever you see this, very, very characteristic, you have to remember it is Kikuchi's disease. So Kikuchi's disease is a necrotic lymphadenopathy without neutrophils, okay, without neutrophils. So there are no neutrophils, but it is due to histiocytes. So histiocytic, necrotic lymphadenopathy, okay, is called as Kikuchi's disease, and it was first discovered in Japan. That is why its name is Kikuchi Fujimoto disease, okay. Remember this, okay. It's a self-limiting disease again, and again there are a lot of virus which are implicated and autoimmunity which is implicated, but usually it resolves by itself. It usually resolves by itself, okay. So that's about Kikuchi's disease. So I told you that there are lots and lots of histiocytes here, okay. So Kikuchi's disease has necrosis along with presence of lot of histiocytes, and these histiocytes you can pick it up on CD68, okay. So whenever I'm saying that a lymph node contain lot of histiocytes, the second differential should come to your mind is what is called as a roside of man. So kahi roside of man to nahi hai. Okay, that's the second differential that should come to your mind. Again, a young male presents with multiple lymph nodes. Okay, so presents with massive lymphadenopathy. And when you did biopsy, what did you found as? You found that there were lot of histiocytes, and all these histiocytes had eaten up something. So there was lot of cells inside these histiocytes. Okay, so there were a lot of cells inside the histiocytes. So this is what is called as emperipolysis. I think somebody asked on my Instagram group also earlier, what is emperipolysis? Whenever macrophages or megakaryocytes eat up other cell, but they don't kill it. So they just engulf it and keep it within them, and they won't kill it. That is called emperipolysis, which is characteristic feature of Rosai-Dorfman disease. So apart from histiocytes, your megakaryocytes can also show you emperipolysis. Okay, so that's his emperipolysis. And somebody asked me, ma'am, what is the difference between entosis and emperipolysis? So entosis means whenever an epithelial cell eats up other cell, that is entosis. Like hepatocytes eating up T lymphocytes in autoimmune hepatitis is an example of entosis. So entosis is seen in autoimmune hepatitis when hepatocytes, which is an epithelial cells, eats up other cells. Okay, so it should be very, very clear. So entosis is seen in autoimmune hepatitis. Okay, emperipolysis is seen in Rosai-Dorfman disease. Okay, that should be very, very clear to you. Okay, now once we are going to this, so again remember, so I've told you what is the markers that you can put for histiocytes. Histiocytes are always S100 positive and CD68 positive, but here is the catch point. So Langerhans cell histiocytosis is a tumor from dendritic cells, and these are positive for S100, but apart from that, they are positive for CD1A, and they're also positive for Langerhans. Okay, so that is LCH, which you should remember. And usually they have grooved nuclei. Okay, so they have grooving, and they have lot of eosinophils. They have lot of eosinophils around it. Okay, so LCH is that condition which always the electron microscopy of LCH is a very typical question which they ask you. A tennis racket shaped structure which is pentalaminar, okay, is typically seen in your LCH, and these are called as Burbeck granules. So what are these granules called as? Burbeck granules. Okay, and of course you should know which is the CD marker for Langerhans. It is CD207. That's a marker for Langerhans which you can use. Okay, so that's about LCH. We should remember again a tumor of dendritic cells. Okay, and it is S100 positive. So S100 is positive in histiocytes. Okay, LCH, cartilage, nerves, melanomas. So it's a non-specific marker. It can come positive in many structures. Okay. Now let's come to this question, which is not true about ALCL. So remember, can you see these cells, everybody? These cells here like this. So these are horseshoe shaped cells. So at places they're completely becoming rounded like donut cells. Okay, or they can become like this, like a horseshoe shaped cell. So either they can be horseshoe shaped or they can be donut cells. Any of these cell morphology seen, these cells are called hallmark cells. What are these cells called as? These are called as hallmark cells. So hallmark cells are very, very characteristic of anaplastic large cell lymphoma. It shows you hallmark cells. And remember, the typical mutation which is seen in ALCL is translocation 2,5. That's a typical translocation which is seen. And usually these tumor cells are CD30 positive. So there is a 2,5 translocation, CD30 positive cells and hallmark cells. And usually whenever this translocation occurs, this causes overexpression of ALK. Okay, and this ALK, whenever it is positive, it gives a good prognosis. That means you can give therapy against it, isn't it? So you can give therapy against it. That is why they are ALK positive. So ALK positive cells carry a good prognosis. They don't carry a worst prognosis. They carry good prognosis. That is what you have to remember. Okay, so that is your ALK, which you all have to remember, ALCS. Okay, so very good, Satvik. You have told about sustentacular cells also, which are His100 positive. Very good. You get 100 points. And Ramya, very good. So tennis racket shaped cells are also seen in embryonal rhabdomyosarcoma. Very good, guys. Okay, so that's ALCL. Now here is another spot question. So if I'm asking you, what is BIA? This is added in the new WHO classification and has become very, very common. This is called breast implant anaplastic large cell lymphoma, which is BIA, and this is very popularly called as seroma. Okay, so if you look at this, this is very popularly called as seroma. You know what did they found? All the females who had undergone these, silicone implants, breast implants. So after a point of time, they started getting fluid accumulation around the trans implants. So they said, okay, why the implants are getting fluid? Probably this is seroma. Later, they took out the biopsy and they found out that this was nothing but anaplastic large cell lymphoma, and that is why it was called as BIA. So this is breast implant anaplastic large cell lymphoma, which is also called as seroma. Okay, so they can ask you what is seroma. It is nothing but it is anaplastic large cell lymphomas. Okay, guys. Now let's come to some questions which can be asked in bladder, guys. Again, a very popular question. Okay, so we have discussed this so many times. Okay, so a person presents with, the raised mucosal plaques about 3 to 4 centimeter. What are these? So these are the plaques in the bladder, which you can be seeing here. So whenever you see this, yellowish plaques in the bladder, this is very, very characteristic of malakoplakia that you have to remember. And remember, because this is yellow, many students confuse it with xanthogranulomatous pyelonephritis. No, guys, remember, this is very, very characteristic. So soft yellow plaques in the bladder is very typical of malakoplakia. And if you're lucky enough, you will be seeing these calcified bodies in it. These are very small calcified bodies. This is, the story that I tell you, so there is a shrub which is given. So these macrophages can eat the bacteria, but they can't kill it. So they have the superpower of calcifying it. Okay, so these macrophages calcify the bacteria. So this calcification is very, very small, and this calcified bodies are called as Michaelis Gutman bodies. What are these bodies called as? Michaelis Gutman bodies. And these superpower macrophages, which have the power of calcifying, these superpower macrophages are called as von Hainsman macrophages. Okay, so this was a person who discovered it. So they are superpower macrophages, okay, which calcify the bacteria. So these are von Hainsman macrophages and Michaelis Gutman bodies. And whenever you see these two, you have to remember the diagnosis is Yomalecoplakia. And that goes for a call. What is a special stain that you can use for calcium here? So because this is a small calcification, so you have to use a stain which is very specific for calcium, that is alizarin red. The other stain which you can use for calcium is von Cosa, but the thing is that von Cosa doesn't directly binds with calcium, it just binds with the oxides of calcium. So it can identify calcium whenever the stores are very big. Okay, then only it can identify calcium, otherwise they won't be able to identify calcium. So therefore the most specific stain for calcium is alizarin red, and it can identify a very minute amount of calciums also. Okay, right. So I told you the another question was yellowish color when they come. So you have to also think of xanthogranulomatous pyelonephritis. Please remember it's a pyelonephritis. So you should have a dilated calyx first. Okay. So you should have a dilated calyx, and these calyx are usually lined with this yellowish material. If you take the biopsy, you will see a lot of foamy macrophages. You will see a lot of foamy macrophages and giant cells. Okay, so a lot of foamy macrophages and giant cells. So whenever there are dilated calyx and yellow material and you see a lot of foamy macrophages, this is very, very typical of xanthogranulomatous pyelonephritis, guys, which you should always remember. So remember the point here. So whenever I'm saying foam cells, okay, so foam cells means something has eaten up either cholesterol, okay, uh, or lipid. That is what changes into foam cells. So foam cells can be seen one in xanthomas, okay, or you have seen in xanthogranulomatous, any condition which is xanthogranulomatous, like xanthogranulomatous pyelonephritis, xanthogranulomatous cholecystitis, okay, or xanthelisma, or it can even be seen in atherosclerotic plaques, okay, atherosclerosis. So, okay, wherever we have cholesterol and phospholipids. So that you all know these are foam cells. Apart from that, you have to remember which are the other conditions where you can see foam cells. In the bone marrow, they're giving you. Never ever forget Niemann-Pick's disease. Okay, never ever forget Niemann-Pick disease, which can be seen. Okay, so Niemann-Pick's disease in the bone marrow, so they give you history of, splenomegaly, mental retardation, and with foam cells in the bone marrow. Think of Niemann-Pick disease. Another, Whipple's disease. Okay, so these foam cells in the Whipple's disease, just now you've seen lamina propria contain undigested bacteria, and they are usually pass positive. They are usually pass positive. So remember that these are the other foam cells. Third, where else? Remember and never forget leprosy, especially lepromatous leprosy. Okay, leprosy has a very high load of lepra bacilli. So this high load of lepra bacilli will be eaten up by the macrophage and they will become foamy. So and if you put Z and stain, they'll be very, very strongly positive, and you will see bundles and bundles of acid fast bacilli, which is also called as globi. Okay, which is also called as globi. So remember that. So leprosy, basically, lepromatous leprosy will also show loads and loads of foam cells. And these foam cells which are seen in lepromatous leprosy are called as, never forget these. What are these cells called as? Virchow cells. These cells are called as Virchow cells. Always remember that. Okay, so these cells are called as Virchow cells. Okay, so these are the conditions where you should see foam cells and your mind should get activated immediately wherever they give you foam cells, and your brain should get activated to answer these questions. Okay, right. So once we're clear with this, now the another question that they can ask you guys, and it is very characteristic, and I've discussed it so many times earlier, so I'll not go into detail. Just a clue that this can come as a tentative question, so you should remember bamboo sticks. Okay, long non-branching tall fibrils, size is 7.5 to 10 nanometer, has to be amyloid, has to be amyloid. Okay, so has to be amyloid, you should remember this. So they can give you anything in amyloid standing from gross, so which is a waxy appearance. Okay, so all the organs increase in size except kidney, because it becomes smaller in size because of ischemia. Bamboo stick-like appearance on the electron microscopy is very characteristic of a myeloid. Okay, if you use Congo red stain, on Congo red stain, it will appear orangish red in color. Okay, so it will appear orangish red in color. Okay, and if you put the same Congo red slide under polarizing microscopy, you will get apple green birefringence. So apple green birefringence is seen on polarizing microscopy of Congo red stained slides. Okay, so that is what you have to remember, the technique and in which technique what is seen. Also remember primary amyloid, secondary amyloid. Okay, remember that AL is primary, seen in myeloma, AA is secondary, seen in chronic inflammations and infections like rheumatoid arthritis. Never forget A beta is seen in Alzheimer's, A beta 2 microglobulin, A beta 2 is seen in chronic dialysis. Okay, ATTR, if it is normal, it is seen, normal ATTR is seen in senile amyloidosis, systemic senile amyloidosis. Mutated ATTR is seen in amyloid neuropathies. Okay, so these all you should remember. Apart from that, which cancer show you myeloid deposition? Remember, medullary carcinoma of thyroid can show you a myeloid deposition. Okay, remember that points always. And if you do X-ray crystallography, what will you see? On crystallography, you have to see the structure. So you will see beta pleated sheets because amyloid is a misfolded protein. So you will see beta pleated sheets on X-ray crystallography. Remember all these questions, guys, it can be asked you in exam. Okay, amyloid is one of the super favorite. Remember the panda eyes, very typical. Remember which coagulation factor is consumed in amyloid? Factor 10. Remember which purpura occurs in amyloid? Pinch purpura. Which cells are first involved in kidney? Mesangial cells. Which cells are involved in liver? Which space? Space of Dicey. Okay, so these are some spot questions that can be asked to you in amyloid. Everybody should be knowing it. Okay, right? Now, once we have seen this, pedigrees, guys, can be given to you as a spot image. Just three pedigrees on the screen. Try to answer yourself. One, two, three. So let's see who answers all the three correctly. One, two, and three pedigrees on the screen. Let me see who answers that. First, you have 2 seconds before I write the answer. Okay, so time over. So when the mother has the disease and she gives the disease to all children, okay, then again mother has the disease, she gives the disease to all children. Has to be mitochondrial. So this is mitochondrial inheritance. Remember, mitochondrial inheritance typically involve muscle, nerves, and eyes. Like the classical example, Murph, Pearson syndrome. Okay, what is MRF? Myoclonic epilepsy and ragged red fibers. Okay, so all these are very, very typical. Okay, so this is mitochondrial. Now look at this. Boys transmitting the disease to only boys, only boy linked. So disease which occurs only in males. Girls have nothing to do with that. Has to be Hollandric inheritance. Hollandric is also called as Y-linked inheritance. The classical example, hypertrichosis. Hypertrichosis. Okay, apart from that, look at this. When the father has the disease and all the daughters become diseased, okay, this is very, very typical of X-linked dominant inheritance. So when father has the disease and all the daughters become diseased, that has to be X-linked dominant inheritance, like Alport syndrome. So Alport syndrome can be X-linked recessive also, guys, but it can be X-linked dominant also, right? So these are some favorite pedigrees of the examiners, which is given in the exam. So you should be able to pick them up real well. Okay, right. So okay, so anything starting with ME, myoclonic epilepsy, usually is mitochondrial. Like somebody asked you what is MELAS, is mitochondrial. That is myoclonic epilepsy with lactic acidosis syndrome. So muscle and epilepsy brain. Okay, right. Okay, so everybody, that should be very, very correct. Okay, so Rett syndrome, vitamin D resistant rickets, perfect, and Alport syndrome are X-linked dominant diseases. Right, guys, perfect. Okay, so very good. So basket weave appearance is typically in kidney, seen in Alport syndrome. Okay, that is alternate thickening and thinning of the lamina densa of the basement membrane. That's T seen in Alport syndrome. Now let's come to three organisms here. What is this one? First organism here. So you see large nuclear inclusion and many small, small cytoplasmic inclusion. Guys, this is CMV virus. Please identify CMV virus can be given to you any place. It can be given to you in brain, it can be given to you in lung, it can be given to you anywhere in the body. So, okay. Uh, That is CMV. So Meghavi is asking why the first one is not autosomal dominant. Guys, autosomal dominant and autosomal recessive inheritance should be made whenever you are not able to identify any pattern. So pedigree is like a video game. You have to identify the pattern. If you're not able to identify the pattern, then only make autosomal dominant or autosomal recessive. Okay, so in this, there was a definite pattern. Father is giving the disease to daughters and all the daughters are deceased. Cannot happen anywhere. Okay, it has to be X-linked dominant. Okay, bacha log. So this first virus I told you, CMV, can be given anywhere. It can be, they can give you owl eye inclusion, they can give you only one eye, big inclusion with lot of cytoplasmic inclusion, and they can give you any organ of the body. Remember that. That's CMV virus, which you have to identify in any organ of the body, right? Apart from that, look at this fungus. A dichotomously dividing fungus, 1 to 2, 2 to 4, 4 to 8, like this. Okay, and all of these are septate. If you carefully see them in high power, all of them have septa here. So septate fungus, which is dividing dichotomously. So remember, who is this? Remember, the name itself says A. I am A shaped, that is, they are acute angle branching and they have septa. So the sign itself of this fungus is aspergillus. That's the fungus sign. That is, it is an acute angle branching and with the septa, and it is very thin. Okay, it's very thin fungus. So it will keep on dividing dichotomously. Okay, so remember, if you have to put a special stain for fungus, you can use either PAS stain or silver methamine stain. Okay, so these are beautiful stains which will come positive for fungus. Okay, right. Now, in contrast to this, if you look at this fungus here, who is this? A mota fungus. Okay, a mota fungus which is branching at right angle like this. Okay, so M for mota fungus. Mota fungus is mucor. Okay, so mucor is mota, so he can't bend at an acute angle, so he bends at right angles. Okay, so mota fungus, okay, branches at right angles, and because he's mota, usually you won't see it dividing dichotomously, so he usually will be sitting singly or with few fungus together. Okay, so that is mucor, which you all have to remember, and the stains are typical, which is your PAS and silver methamine. Okay, so I'll show you an image, guys. Okay, and many of the students did this question wrong. Okay, so which fungus is this? Again, there are pink colored, pink colored abnormally branching structures here. Which fungus? Is this a fungus? Many students did this question wrong. So what is it? This is not fungus. This is what is called as lacy osteoid. Okay, so it's lace like osteoid, guys. This is lacy osteoid that you should remember. This lacy osteoid is very typically seen in osteosarcomas. Okay, so normally if you look at osteoid or bone, it is usually thick, well formed, but you see here it is like lacy. It's flowing like anything haphazardly. So this is called lacy osteoid, which is seen in osteosarcoma. Don't do this question wrong. Let me show you the question now so that you never do this question wrong. If I give you gross, everybody would have made it correctly. मैम ये तो बोन है, इसके अंदर एक इतना बड़ा सा ट्यूमर आ रहा है जो कि पेरियोस्टियम को लिफ्ट कर रहा है. So this is your osteosarcoma. बना दिया सबने. Okay, but without seeing the cross, okay, something pink which is haphazardly flowing like this, haphazardly, this has to be osteoid. Okay, so Meghavi says it can be blood vessels. Guys, blood vessel is like this. Can you see the structure here? This well luminal structure here, this is a blood vessel. Okay, but this is a solid hollow pink color structure like this, so it's an osteoid. Okay, samajh mein aa gaya? Okay, so that's the difference. Okay, now let's come to the question. Okay, so let's see how many of you can answer this. So this is a 12-year-old female which has an intramedullary mass in the distal femur. It was resected, and this is what is seen. What will be the best answer to this question? So remember, best answer they've asked you. Okay, so remember, this tumor usually occurs because of amplification or mutation of MDM2 gene. That's the classical mutation which is usually seen in osteosarcomas. Okay, so osteosarcomas usually have MDM2 mutation, which you have to remember. Now, in contrast to this, look at this again, and another image I've shown you. So what is this? Now this is solid. Okay, solid bony trabeculae, but it is not standing in a line. It's bending abnormally like this. Okay, so it's bending abnormality like a hooks. It's bending. So it is also called as Chinese letter appearance. Okay, so this is also called as Chinese letter appearance, which is typically seen in fibrous dysplasia. Which is seen in fibrous dysplasia. Okay, so fibrous dysplasia people usually have GNAS mutations. Okay, so remember, GNAS mutation, which I've discussed yesterday, also can be very commonly seen in pituitary adenomas. Apart from that, GNAS mutations can also be seen in IPMNs, which we talked in pancreas yesterday. Okay, so intraductal papillary mucinous neoplasms of pancreas. Apart from that, GNAS mutations are very common in fibrous dysplasias also. Perfect, guys. Very good, Avantika. That's correct. Okay, so remember this. Okay, so that is your fibrous dysplasia, which has Chinese letter appearance, which you can see in this cases. Okay, so that's your fibrous dysplasia. Now let's come to some gynae tumors, which are classically asked in your exam, and they usually give you. Guys, my screen is moving. Can you see this? I think my screen is not moving. Can you see the screen of the gynae tumors together? Okay, Ramya. Okay, Megha. Okay, don't worry. But you're able to hear me, right? Yes, everybody has understood fibrous dysplasia, right? Okay, don't worry, don't worry. You'll be able to see the screen now. Wait. Just give 2 seconds to yourself and to me also. Now is it seen? Yes, let's see. Stuck? Oh, Baba. Still not? Wait. Okay, so can you see my screen now? Wait. Now also you can't see the screen? Okay. But you can hear the sound correctly, no? Just a second, let me see. Wait. Mm, Wait. Screen sharing.
Share this तो रही वहाँ से वो करो स्टॉप करके स्टार्ट करो नीचे शेयर द स्क्रीन स्टॉप स्टॉप स्टार्ट करो आएगा अभी
Coming.
Network చూస్తే మనకి network కొంచెం
Network is okay.
restart करना फटाफट से
Is it coming out? I know you can hear, guys. Okay, no worries. Screen is going to come now. Okay, so now once you've talked about this, let's come to the gynae tumors, which can be asked you in exams. Okay, so all of you I know have studied your gynae and obs very well. So, but there are three images in the gynae tumors which they can ask you, and you should be very clear with this. Okay, so definitely wait. Okay, wait. Okay, so till the time the screen comes, okay, maybe some network issue, it's okay, but at least you're hearing me. So who's going to tell me what is the which are the structures that you will see on yolk sac tumor? So if it is a yolk sac tumor in males versus females, what is the difference? That's the first question. And which bodies will you see in yolk sac tumor? Yolk sac tumor is also called as endodermal sinus tumors, guys. You know that, okay? So, if I'm talking about endodermal sinus tumors, so I hope everybody knows that in endodermal sinus tumors, we get typical bodies. What are these bodies called? Okay, tell me which bodies will you see in endodermal sinus tumor or yolk sac tumor? And you have to tell me what is the difference between males and females. Quick, tell me. I'm waiting for your answer. Very good, Satvik. So I'm sure all of you know these bodies. I hope you can see the screen now, guys. These bodies are called as Schiller dual bodies. Okay, so these are called as Schiller dual bodies. Remember, how are they? They are like a blood vessel, which Megha told. Okay, so there's a blood vessel in the center. Around the blood vessel, there'll be columnar cells which will be arranged. Okay, which will be arranged like this, and there'll be a space around that. These are called Schiller dual bodies, which are seen in yolk sac tumors, guys. Okay, you should be very clear with this. Okay, don't confuse it, okay, with any other body. And if I'm talking about the difference between the males and females, you should remember, in males this tumor usually occurs in males which are less than 2 years of age, and usually the tumor doesn't have any areas of hemorrhage and necrosis, and it has an excellent prognosis in males. So the prognosis of yolk sac tumor in males is excellent. Okay, whereas when I'm talking about females with yolk sac tumors, they usually occur in a middle-aged female, and they have areas of hemorrhage and necrosis, and the prognosis is not very good. Okay, prognosis is not very good. That's the difference. Remember, yolk sac tumor in males have an excellent prognosis. Yolk sac tumor in females do not have a very good prognosis, and all of these yolk sac tumors, they secrete alpha fetoprotein. So the tumor marker for yolk sac tumor is alpha fetoprotein, and therefore they have Schiller dual bodies. And because there is lot of alpha fetoprotein, it can form hyaline globules. Okay, so they can show you formation of hyaline globules. So they can ask you which tumor, which ovarian tumor has hyaline globules. Remember, it is Schiller dual body. It is yolk sac tumor. Apart from that, another condition where you see hyaline globules, apart from yolk sac tumor, guys, is hepatocellular cancer. In hepatocellular cancer, also you will see hyaline globules. Apart from that, alpha 1 antitrypsin deficiency in liver will also show you hyaline globules. So these are the conditions where you see hyaline globules. You should be very clear with it. Okay. Now, these Schiller dual bodies resemble the fetal glomerulus because there's a vessel, there is a columnar cells, and there's a space. So it looks like a fetal glomerulus. Always remember that. Okay. Now, once you're clear with this, let's come to the next bodies which I've kept on the same screen so that you don't do wrong in exam. Okay, follicle-like structures. So if you look at them, they are follicle-like structures, and if you carefully look at them, all these nuclei are bent. Okay, so if you look at this nuclei, okay, so all of them have some grooves in them. Okay, so all of these nuclei are grooved nuclei. They're not perfectly round nuclei, they are grooved nuclei, which you should remember. So these grooved nuclei are called as coffee bean nucleus. What is this called as? Coffee bean nucleus. So they have grooved nucleus, coffee bean nucleus, which are forming follicles, and these bodies are called as Call-Exner bodies. What are these bodies called as? Follicle-like bodies. They are called as Call-Exner bodies, and sometimes they can have that pink material inside them, and some of the times they don't have that pink material. It's okay. Okay, so they are coffee bean nucleus in Call-Exner bodies, and the mutation that you see here is, okay, FOXL2. The mutation that you see here is FOXL2, which you all have to remember. So that's FOXL2. Okay, so whenever I'm talking about FOXL2 mutation, so how do you remember this tumor? This structure is typically seen in granulosa cell tumor. Please remember, this is seen in granulosa cell tumors. So who is this? Name itself says gran. So it's a granny. Okay, so it's a grandmother. Okay, so it's a very elderly female who presents with postmenopausal bleeding. Okay, so there is a postmenopausal bleeding. So that's a typical history that is seen here. Why? Because granulosa cell tumor is a very girly tumor. G for G, very girly tumor. It secretes lot of estrogen. Okay, it secretes lots of estrogen, and that is why, because it secretes lot of estrogen, it's a very girly tumor. You know what's the characteristic feature of girls? Say something happens to me, it should have happened to my friend also. Okay, so first, if one ovary is involved, it will definitely go and involve the other ovary first, and it is girly, so it secretes a lot of estrogen. Okay, so it secretes a lot of estrogen, and that is why the females can present with endometrial hyperplasia. So any postmenopausal female normally on a pap smear should have parabasal cells, but if she has a granulosa cell tumor, you will start getting superficial squamous cells on the pap smear. That is why this is one ovarian tumor that you can suspect on pap smear itself. So which ovarian tumor you can suspect on pap smear itself? Granulosa cell tumor. And you know, it's a very girly tumor. So girls love to drink coffee, okay, and they love to make fox faces. Okay, so there is a characteristic feature nowadays. They love to make fox faces, okay, foxy eyes, and they love drinking coffees and coffee beans, and they'll call their friends and say, colleagues, now come, let's have coffee. Okay, so remember, granulosa cell tumor is a granny who presents with lot of estrogen, so can be picked on pap smear. She calls her friend, drinks the coffee, and tries to appear foxy. That's a very characteristic feature of granulosa cell tumor. Okay, and of course, you all know, so see, she's a girl. So she has some inhibitions. So this is inhibin. Okay, so it is also positive for inhibin. It's also positive for inhibin, that you have to remember. So Vantika, you've drawn a beautiful fox. Thank you, foxy girl, right? Okay, so that's your granulosa cell tumors, which you all have to remember. Okay, once you're clear with this, look at the third tumor that they give you in exam. This is like a cut potato appearance. It's a very homogeneous, bulgy tumor, like a cut potato. Okay, so this is called cut potato appearance. It's a very cellular, bulgy tumor. Okay, and this is cut potato appearance. And if you look at this at high power itself, what catches your eyes is that the tumor cells are very clear. Okay, so the tumor cells are very clear. This is because they are usually polygonal tumor cells, and they have round nucleus and prominent nuclei, and the cytoplasm is very clear. Cytoplasm is very clear. Okay, so it is a very clear tumor, but you can see that there are septa here, and these septas are usually infiltrated with lot of blue cells, that is lymphocytes. So there is a fibrous septa which is infiltrated by lymphocyte. So if this is a male, this tumor is called seminoma. If this is a male, this tumor is called as seminoma. If this is a female, the same tumor is called as dysgerminoma. So morphology of both the tumors are same. Okay, just seminoma in male, dysgerminoma in female. The tumors are very clear. Okay, so they have a watery cytoplasm and they have a septa which is infiltrated by lymphocytes. So these are seminomas and dysgerminomas. Always remember. Okay, so they have positive for OCT3/4. Okay, so they are positive for OCT3/4. So make Harvey. This is not palisading. I'll be showing you palisading in today's session itself. Don't worry. I'll teach you that. What is palisading? Palisading means when everybody stands in a line. They're not standing in a line. There are clear cytoplasm. There's a septa infiltrated by lymphocyte. Okay, so they are positive for OX3/4, NANOG. Okay, these are the markers which are usually positive for seminomas. Of course, we're going to talk about SOX. So they are usually positive for SOX17, and PLAP is usually positive. Okay, so PLAP is usually positive. Okay, so they are OCT3/4 positive, NANOG positive, SOX17 positive, and usually PLAP positive. Okay, so these are the tumors in the gynae, which at least you should remember. Of course, leiomyoma is another tumor that you should be knowing, because that's one of the most common benign tumor of the uterus. Okay, of the myometrium, which you should know, leiomyomas. Okay, I've not put a picture here, but remember leiomyoma, you should remember. Okay, right. Okay, guys. Okay, so this is important. And yes, we one more thing. So SAL4 is the new marker which has come out to be positive in this. So remember, SAL4 is also very important. And if they talk about the translocation in seminomas or dysgerminoma, it is isochromosome 12p. Okay, so isochromosome 12p is very common in seminomas. Okay, right. So that is your seminomas, York tumors, and granny tumor, which all of you should be knowing. Okay, so here's the spot question for all of you. Let me see how many of you can answer this. We have already discussed this in rapid fire hemat quiz. FOXP3 is a marker for which? So FOXL2 you have studied now, no? FOXL2 you have studied is granulosa. Okay, so everybody wants to be like Fox, granulosa. Yes. So what is FOXP3? Who's going to tell me this? Quick, guys, tell me. So regulatory T cells. Okay, regulatory T cells. Okay, so regulatory T cells are very characteristic. Okay, regulatory T cells are very typically having FOXP3 marker. FOXP3 is a marker for regulatory T cells. And if there is deletion of FOXP3, if there is a deletion of FOXP3, we get a immunodeficiency syndrome, which is called as IPEX. So there is an immunodeficiency syndrome which is called as IPEX, which occurs because of deficiency of FOXP3. Always remember that. So FOXP3 is a marker for regulatory T cells. Okay, always remember that. Okay, perfect. Once we are clear with this, now let's come to another important question that they give you in exam. So let's see how many of you can answer this. Okay, so this is a 25-year-old male who developed his swelling on a big toe, and excision showed you this. What is this? What do you think is the diagnosis of this condition? So there is some homogeneous pink material which has come out. So what is this? So guys, you should never forget, this is nothing but gout. This is nothing but gout. So gout has a lot of needle shaped crystals. Okay, but problem is that these needle shaped crystals get dissolved in formalin. Okay, so when you put them in formalin, they will dissolve and they will leave behind this amorphous pink material. And because gout causes lots of inflammation, lot of neutrophilic inflammation, it is very dangerous. It causes lots and lots of inflammation. You will see a lot of giant cells and inflammatory cells in the periphery. So that's a characteristic image of gout, which you can see. So it has an amorphous pink material, and it is because these needle shaped crystals dissolve in formalin. That is why you have to if you're suspecting gout, you have to put the tissue in alcohol. Okay, so alcohol should be used as a fixative, or you should use non-aqueous fixatives. Okay, you should use non-aqueous fixatives, or you use alcohol as a fixative. Then you will be able to see. And the ideal way of seeing this needle-shaped crystal is with polarizing microscopy. So if you use polarizing microscopy, you will be able to identify these needle-shaped crystals. So on polarizing microscopy, you should be able to see these needle-shaped crystals. Remember, always the rule is gun. Okay, so gun. Okay, you should always remember. So gout crystals are like gun. Okay, so because they are urate crystals and they are needle shaped and they have negative birefringence. Okay, so that is your gun. Okay, needle shaped, negative birefringence. Okay, so needle shaped, negative birefringence urate crystals is very typical of gun. Whereas if you go opposite, okay, pseudo gout is PCR. Okay, so remember pseudo gout is PCR. What is PCR? That is that they are made up of calcium pyrophosphate. They are made up of calcium pyrophosphate and they are rhomboid shaped crystals. So they are rhomboid shaped crystals like these. So they are rhomboid shaped crystals. Okay, and they are calcium pyrophosphate and they have positive birefringence. They have positive birefringence. Okay, so they have positive birefringence, which you can see. So that is your pseudo gout, which you all have to remember. So that's gout and pseudo gout, but we don't finish the reaction here. So which is the microscopy on which you can see these crystals? This microscopy is called as polarizing microscopy. What is this microscopy called as? Polarizing microscopy. And polarizing microscopy, how is it different from the other? This is because they have a special mirror which is called as dichroic mirror. Okay, so they have a special mirror called as dichroic mirror and they allow only one wavelength of light to pass. Okay, so dichroic mirror is present in which type of microscopes? Polarizing microscopes. Okay, apart from that, flow cytometry also has dichroic mirrors. Okay, so that is it. Now suppose on polarizing microscopy you see these Maltese cross crystals. Okay, so then you should think of porphyria. Okay, so Maltese cross crystals on polarizing microscopy should make you think of porphyria. So remember I told about Maltese cross structures in the RBCs. So do you remember I told you that is babesia, whereas Maltese cross structures seen on polarizing microscopy has to be porphyria. Okay, so that's your porphyria in which you can see these Maltese cross structures. Okay, that is what you all have to remember. Okay, and if you use a Congo red slide and you see it in the polarizing microscopy, then and if you're getting apple green birefringence, then you have to think of amyloid. Okay, now coming to the next technique which they can ask you is immunofluorescence, and full house effect is seen in SLE. All of you know that. And you know what is full house effect? When it is positive for all the immunoglobulins C3, C1q and fibrinogen. That is what is called as full house effect. So full house effect is seen in typically SLE. Okay, so that is your SLE which you all have to remember. So on immunofluorescence, you should remember that majority of the immune complex mediated deposits show you granular immunofluorescence. Linear immunofluorescence, that means when all the basement membrane shines, is seen in anti-GBM disease. Okay, and in whenever I'm talking about granular, this also you have to remember. So majority of the immune complexes show you granular immunofluorescence. Okay, but sometimes they can ask you as a question, starry sky immunofluorescence or garland pattern of immunofluorescence is very typical of which disease? This is post-infective glomerulonephritis, which is also called as post-streptococcal glomerulonephritis. Okay, so that is your starry sky or garland pattern of immunofluorescence. If they give you that in granular, that is PIGN or PSGN, that is same thing, post-infective or post-streptococcal. Apart from that, if they give you only the mesangial cells are highlighted, on the immunofluorescence and others are not, then you should think of IgA nephropathy. Then you should think of IgA nephropathy. So in granular also they can ask you as a question, remember starry sky or garland pattern or mesangial. Okay, that's a very, very important that they can ask you. Okay, of course, acute proliferative glomerulonephritis is also the name which is given to post-infective glomerulonephritis. Okay, uh, but it can be seen in other conditions also. It can be seen in other conditions also. Okay. Now, let's come to some update. So there is an oncometabolism, which all of you should know. Okay, so what is an oncometabolism, guys? Whenever we have targeted therapy against some enzymes, so enzyme mutations are very common in IDH mutations. IDH mutations were first discovered in oligodendroglioma. After that, we started inventing it in other tumors also. Now we have seen them in AML, breast cancers, and cholangiocarcinomas, and more are being discussed. So that is isocitrate dehydrogenase mutation. The second one that you have to remember is fumarate hydratase enzyme, FH. Fumarate hydratase enzyme mutation is seen in papillary carcinoma of kidney. Here you should remember papillary carcinoma of kidney is one cancer which usually arises in dialysis patients. Okay, so which cancer arises in dialysis patient? This is because they develop acquired cyst and they can have, papillary carcinomas. Then succinate dehydrogenase mutation, we have talked about it yesterday also, pediatric GIST and pheochromocytomas. Okay, so pheochromocytomas, these are the conditions where you will see your SDH mutations. So SDH mutations are seen in pediatric GIST and pheochromocytomas. So these are oncometabolism. Apart from that, you have to know what is an inducible pluripotent stem cell. Is one which can be induced from any mature cell into a stem cell with the help of pluripotency markers. So what are considered as a pluripotency markers? SOX2, OCT34 and c-KIT. So these are usually considered as pluripotency marker, which you all have to remember. Apart from that, SOX genes you should remember. SOX17 you have studied just now in seminoma. SOX2, 2 is like heart, so it occurs in embryo. Embryonal cancers are SOX2. SOX11, we have already talked in the rapid fire hemat discussion, is mantle cell lymphoma. SOX9 is very important. Okay, so now SOX9 is typical for chondrosarcoma, especially mesenchymal chondrosarcoma, and SOX10 is a Schwannian marker. Okay, so it is a pan melanocytic and Schwannian marker. So these are the SOX markers which all of you should be knowing very well. Okay, so when we talk about Schwannian, nothing is complete without this tumor. Okay, so nerve tumor, which you all have to remember, and this is one of the first jinx question which I had first predicted a long back, and it came in the exam the next day. So this is one of my favorite questions, showing you cellular as well as hypocellular areas, Antony A and Antony B areas, and in the cellular areas you will see bodies with peripheral palisading. So this is what is called as palisading, guys. Can you see this? All the tumor cells are arranged in line. So now you remember here, guys, so this palisading of the nucleus on both sides with the pink material in the center, which you're seeing here, are called as Verrucke bodies. What are these bodies called as? Verrucke bodies, and they're typically this is a typical structure of a tumor called as schwannoma, which usually occurs because of which mutation? NF2 mutation. So the mutation which you see here is NF2 mutation. So who will tell me that NF2 mutation is typically seen in which all tumors? It is seen in schwannoma, ependymoma, and meningioma. So remember the code SCEM, schwannoma, ependymoma, and meningioma. So guys, here is the catch point that I have to tell you here. So whenever I'm talking about palisading, no, we can have true palisading. That is, cells are arranging themselves by their own will. They're standing like this. Okay, so they're standing by their own will like this. Okay, so like you're studying by your own will. Okay, by at 1 o'clock in the morning. So that's your own will. That's true palisading. So true palisading is seen in one. Just now you've seen Verrucke bodies of schwannoma, Or the second place where you can see true palisading of the nucleus is in basal cell carcinoma of skin. So we have verruca body and basal cell carcinoma of the skin, which show you true palisading. Okay, so they are true palisades. Okay. Second is pseudo-palisading. Pseudo-palisading means you don't want to study, but somebody is forcing you to study. So there are blood vessels on one end and there is necrosis on the other end. And so because of necrosis and blood vessel, you are made to stand in a line. You don't want to stand in a line, but you are made to stand in a line because of necrosis and lot of proliferating vessels. So this is what is called as pseudo-palisading, which is typically seen in glioblastomas. Okay, so glioblastoma shows you lot of pseudo-palisading, and the necrosis here keeps on growing. So that is why this necrosis is called here as serpentine necrosis. And because there are a lot of proliferating vessels, okay, which are not formed well, these are called as glomeruloid vessels or glomeruloid structures. Okay, so glomeruloid structures or glomeruloid bodies are typically seen here in glioblastoma. Very, very important, guys. It's a highly malignant tumor of the brain. Okay, remember that. Okay, and I told you IDH mutation can be seen in it also. So if it is IDH mutated, such glioblastomas have a better prognosis, whereas IDH wild type has poor prognosis. So IDH wild type, when the IDH is not mutated in glioblastoma, they are usually poor. Whereas whenever the IDH is mutated, that has a better prognosis. And because the serpentine necrosis will keep on growing from one hemisphere to the other, this is also called as a butterfly tumor, and it has lot of proliferating vessels and necrosis, so it's a grade 4 tumor. Perfect, guys, everybody. So which type of glioblastoma has a better prognosis? IDH mutated type, and this type of glioblastomas are usually secondary glioblastomas, where IDH wild type are usually primary glioblastomas. Okay, so that is what you have to remember also. So that's about palisading. So now nothing can stop a resident without showing you two CVCs, because hemat is my favorite. So nothing ends without hemat. So what do you see here, guys? Look at this. This is a 25-year-old female coming for the antenatal checkup. Look at her RBC count. It is 6.3. Okay. And look at her MCV. It's so less, 64. So whenever you're looking at this, that means the cells are microcytic hypochromic, but still the RBC is more. That means there is something destroying the RBCs, and that is why bone marrow is producing more RBC. That means there is some hemolytic anemia going on. And if you calculate Menzer index, that is MCV by RBC here, so you see 64 by 6.3. So definitely it comes out around less than 13. So this is very typical of beta heterozygous thalassemia or beta thalassemia trait. So if you want to confirm the diagnosis, what is the diagnosis of choice? You should go for hemoglobin HPLC, and if the hemoglobin A2 is more than 4, you should make a diagnosis of beta thalassemia trait. Okay, and we have discussed this question also in rapid fire hemat session, where I told you that hemoglobin A2 more than 4 is beta thalassemia trait, but if your hemoglobin A2 values become more than 8, then you should think of hemoglobin E, which is very common in the northeast part of our country. Okay, that is what you have to remember. So hemoglobin A2 more than 4 but less than 8 is beta thalassemia trait, and if your hemoglobin A2 goes more than 8, okay, patient will present like beta thalassemia trait only, but it will be hemoglobin E. So that is why the diagnosis of choice is hemoglobin HPLC. Okay, so high performance liquid chromatography. Okay, that's it. Okay, now, okay, so now here is a very important, again, a question that you should see here is RDW, guys. So if you look at the RDW, you should ideally, so we have two type of RDW, SD and CV. So whenever we look at RDWs, we see at SD because it's a direct parameter, whereas RDW CV is actually dependent upon MCV. So RDW CD is RDW SD by MCV. Okay, so it is dependent upon your MCV. So that is why it is not a good parameter. So normally RDW remains normal in cases of beta thalassemia trait, but if RDW is increased, then it can be a coexistent iron deficiency anemia in a beta thalassemia trait, which is very common in our country. Okay, so that you have to remember. So normally RDW is usually in the normal range in beta thalassemia traits. Okay, but can it be increased in beta thalassemia trait? If it is having coexistent iron deficiency anemia, yes, then RDW can be increased. Okay, right. So normally also, if you, yes, very good. Okay, so normally this is not very high, guys. Okay, this is not very high because up till 15, 14.5, 14 is normal. Okay, so it's not very high. So if it is an iron deficiency, your RDW will go like 23, 25, 26% like that. Okay, right. Now, once you've seen the CBC, here is another CBC which you should be knowing, and this can be asked you in exam. Let's see if you can answer this. Look at this question. So just opposite to the earlier counter, here the RBC count is very less, 0.7. The RBC count is very, very less. Okay. But if you look at the MCV, it's very high, 121. MCH is also very high. I hope you remember normal MCH is 28 to 32. Here it is 167. MCHC is also very high. Normally it's 32 to 36, but here it is 138. Okay. No. Some of you will say, ma'am, this is megaloblastic anemia. So if it is megaloblastic anemia, your hemoglobin should also go down, but hemoglobin here is normal, 11.9. So what is it? What is it, guys? So MCV is increased, MCH is increased, MCHC is increased, RBCs are decreased. That means some cell is so big. Counter is counting the cell as such a big cell. Okay, so this can happen when your smear has this. What is this? Agglutinates. So whenever your red cells have agglutinates, what is going to happen is these big agglutinates, the counter will count it as a big cell. So obviously the number of cells which are passing through the counter will become less. So your RBC count will go down, but your MCV will be very, very high. Your MCV will be very high. Okay. So somebody says it's a megaloblastic anemia. If it is a megaloblastic anemia, your RBC count will not be so low. It will be like 2.5 like that, and your MCV will not be so high. Your MCV will be like 105, 110, like that. It will not be to 120s, and your MCHC will always be normal in megaloblastic anemia. Okay, MCHC should always be normal in megaloblastic anemia. Here MCHC is also increased. That's a very important clue, guys. Okay, so MCHC is always normal in megaloblastic anemia. So here MCHC is also increased. That is why you should always think of cold agglutinin disease. This is cold agglutinin disease. If somebody asks you, tell me one parameter which remains normal in cold agglutinin disease, it is always hemoglobin. You know why? Because hemoglobin is counted by the machine after the red cells are lysed. So when your red cells are lysed, the hemoglobin is estimated. Okay, by first it was estimated by hemoglobinocyanide method. Now it is estimated by sodium lauryl sulfate method. So that also can be asked. How do you estimate hemoglobin? By sodium lauryl sulfate. Okay, that's the method by which the blood machines count the red cells now, hemoglobin now. Okay, hemoglobin count is counted by sodium lauryl sulfate. Okay, so that is why, because its red cells are lysed, so all the agglutinates are broken down, and that's why hemoglobin always comes in a normal range in cold agglutinin disease. All the other parameters are wrong. So what should you do? Warm the sample, and then you see, when you warm the sample, then what is going to happen? The red cells will separate from each other and your parameters will become okay, right? Now, some of you said this is hereditary spherocytosis. Okay, guys, so in hereditary spherocytosis, what happens is all the other parameters are okay. Only MCHC is increased. If only MCHC is increased, okay. So remember the two parameters which are increased in spherocytosis is MCHC and RW. So if only these two are increased, think of HS. Okay. When will you think it is a megaloblastic anemia? When your MCHC is normal, but MCV is high. Then you will think of megaloblastic anemias. Everybody, are you clear with this? Okay, don't do this wrong. Okay, now if your MCV is high, MCH is high, MCHC is also very high, and your RBC is very low, then you should think of cold agglutinin disease. A very, very important chart, guys. You should remember that. Okay, right? And okay, it can come in your exams, so you should be knowing this. Okay, so that's very, very clear that you should know. Okay, so Megha, we don't get trapped in exams. Okay, in exams you should be doing it correctly. So with that, guys, it's already 1:15 like yesterday. So I'll say keep practicing, keep reading and doing, do lots and lots and lots and lots of questions, guys. And definitely do look at my Instagram or Facebook or Telegram. Just one day before the exam, I'll post some tentative questions which I feel can come in exam. Yes, and revise the sessions which we have done over the past 4 days, which is very important. So whenever you have time, please keep practicing and reading, because that's going to lead to success. Keep calm, keep your mind calm, keep practicing, take a deep breath. You know everything. Nobody knows more than you. You have read everything, and you will definitely win. Okay, you will definitely do. Thank you, guys. Do look at the questions just last day before going to the exam. Okay, if you have time, you can follow me on Insta, Dr. Vandana Pathology. My video lectures on doctor tutorials. Facebook, Dr. Vandana Pathology Study Circle. YouTube is Dr. Vandana Puri, where you're seeing. And Telegram, we'll have quizzes as always at 11 p.m. because that time is the special power time, as you say, on Dr. Vandana Pathology. With that, I will say thank you guys for watching and all the very, very best for your exams. Bye bye. Do very well. एग्जाम से पहले आशीर्वाद is with you. Don't worry, Satvik, Ramya, everybody out there, Meghavi, everybody out there. Okay, Alchemist, which I don't know the name also, Cielo, whoever is there, everybody of you, may you get selected. May we meet in some medical college. Okay, and maybe you can identify me and I can identify you in some conference where we meet. Definitely do very well, be super successful in life and do super, super, super good. Okay. Thank you, Divya, and do very well in your exams. I pray for your success, and I hope we meet on the other part of the table now. Right? Okay, guys.